Dr. Gao, now that we know what goes into understanding a patient's disease, I'd like to talk about treatment, starting with treatment goals. How do goals vary by patient, if they vary at all?
Sure. Yeah, I do think they vary. And I think it is important to be clear about what the realistic goals of treatment might be so that the patient can make an informed decision on how the prostate cancer should be treated or managed. So some prostate cancers are highly curable, although there isn't anything that's 100%, right? And others are curable, but we acknowledge that there may still be a significant risk of relapse despite treatment. And maybe that rough percentage, right, the probability of cure and sort of the potential downsides or side effects of treatment, that's something that the patient has to weigh in terms of, whether they want to proceed with that treatment or not. And then there are cancers, and especially with advanced prostate cancers, right, that are unfortunately not curable, but yet treatments have the ability to significantly prolong somebody's life, to slow the cancer progression down or even to shrink it, and to improve cancer-associated symptoms, things like the pain and urinary symptoms and other, sources of distress that we talked about earlier. And so for each patient, I think it is important to talk about these treatment goals because it may not be, readily clear, is this a curable cancer or not? And it might not be clear how much benefit they might expect with treatment, or are we talking about a marginal benefit? And that way, they can think about it, talk about it with their family, and kind of, factor into their overall benefit risk calculation about whether to do something or not.
Yeah. Would you provide an overview of current treatment options for advanced disease?
Sure. It's a big, it's a sort of very open-ended question, I think. Yeah. I think you can divide it up into sort of the major treatment modalities. So things like radiation or radiation types of therapies, chemotherapy, hormonal therapies, which are the mainstay of prostate cancer treatment, targeted therapies, and immunotherapies. Okay, so starting with hormonal therapies, which are the backbone of prostate cancer treatments. For advanced prostate cancer, androgen deprivation therapy, or ADT, is often given indefinitely. That's the typical standard of care treatment. And there are various forms of ADT, most commonly in the form of long-lasting injectable medications, leuprolide, goserelin, sometimes daguerreolex is used. And then more recently, there was an FDA approval a couple of years ago of an oral pill called relugolix, which is also a form of ADT, or androgen deprivation therapy. And these medications block the body's ability to make testosterone, which is important for prostate cancer survival and spread. In addition, abiraterone is an oral medication that is also considered a hormonal therapy. It blocks the production of androgens, or male sex hormones, outside of the testes. That includes the adrenal glands and some other tissues, such as the prostate cancer itself. And abiraterone is commonly used in advanced prostate cancer management, in addition to androgen deprivation therapy, whereas ADT blocks the testes from making testosterone and androgens. Abiraterone blocks the production of androgens outside of the testes. And then finally, oral anti-androgen medications that block the prostate cancers from being able to detect androgens or male hormones, and to block the androgen receptors on prostate cancers from sending cellular signals for growth and survival, are also very commonly used. There are older anti-androgen medications like bicalutamide, flutamide, nalutamide, and there are newer ones, stronger versions called enzalutamide, apalutamide, and darolutamide. And for most patients who present with advanced prostate cancer, I think this is key here, ADT along with either abiraterone or one of the newer, stronger anti-androgens is the standard of care for most advanced prostate cancer patients with metastatic disease. And then sometimes for patients with on the sort of with higher volume or more aggressive cancers, even in the group with metastatic disease, we even add on another treatment, usually chemotherapy, something called docetaxel for what we call triplet therapy. Okay. And then maybe that's a segue to chemotherapy. So docetaxel chemotherapy is a common chemotherapy used for prostate cancer, certainly advanced prostate cancers. Cabazitaxel is also a common chemotherapy in this situation. These two are related drugs in a family of drugs called taxane chemotherapies. And basically they kind of block the trafficking of important components within cancer cells and leads to prostate cancer cell death. So docetaxel is the more commonly used one. It's typically used earlier before cabazitaxel. And like I said earlier, for certain patients with what we call high volume metastatic prostate cancer, it's often used in combination with hormonal therapies early on, what we call upfront therapy for 6 cycles. If a patient doesn't receive docetaxel upfront, docetaxel is commonly used after progression, after the cancer has progressed on ADT and one of the oral hormone medications. Cabazitaxel is more commonly used after a patient has previously received or progressed on docetaxel. Both drugs have been evaluated in randomized phase 3 clinical trials and have shown to be to provide efficacy for patients with advanced prostate cancers. In addition to these taxane chemotherapies, platinum chemotherapies, such as carboplatin and cisplatin, are sometimes used for advanced prostate cancers as well, especially for certain neuroendocrine or small cell prostate cancers. These are rarer cancers, but they tend to respond better to platinum-based chemotherapies. Or for certain what we call aggressive variant prostate cancers, these platinum-based chemotherapies are often used in combination with either one of the taxanes or with another chemotherapy drug called etoposide. Okay. In terms of other treatment modalities, I think recently what we call radiotherapeutics or radioligand therapies have gotten a lot of press with the approval of a new medication called lutetium PSMA or 177 lutetium PSMA 617. The brand name for that in the US is Pluvicto. And what this is a drug that's a small molecule that binds to PSMA, which is a protein highly expressed in close to 90% of prostate cancer, advanced prostate cancers. And the small molecule will home to the cancer, and it's linked to radioactive lutetium. And the lutetium will decay in that area and lead to cancer cell death. And so Pluvicto or lutetium was FDA approved in spring of 2022 based on randomized phase 3 trials that showed significant efficacy for patients with metastatic castration-resistant prostate cancer who have previously received a second-generation androgen receptor pathway inhibitor, such as abiraterone or enzalutamide, as well as a taxane chemotherapy like docetaxel or cabazitaxel. The medication is given intravenously once every 6 weeks for up to 6 doses. And there are ongoing clinical trials actually that are trying to evaluate this medication in earlier settings where patients haven't gotten prior chemotherapy before. And there was a press release from about half a year ago stating that they're seeing some early encouraging signs of efficacy with this drug, even in patients who have never received chemotherapy before. So it may be a medication that is going to be used more and more so in more patients, even earlier in their course of disease.